Acute kidney injury, kind of in its simplest form, is an acute decrease in the GFR that causes either reduced urine output or an elevation in the creatinine. AKI is typically recognized via an elevation in the creatinine, in part just because we're monitoring the creatinine so much when people are admitted to the hospital. Although an abrupt drop-off in urine should also be alarming to us to really investigate and look into whether or not there could be acute kidney injury. Mostly, though, I think we pick it up in the creatinine. The most common causes for what we do as hospitalists in the inpatient setting is definitely going to be volume. Now that can be too much, like low cardiac output in the setting of heart failure, or too little, like hypovolemia from a number of things. Usually it's infection or sepsis. And it's especially tricky when that's part of the initial presentation. Once people come into the hospital, once they've been admitted for a day or two, then some form of ATN or acute tubular necrosis, which I'm using as a broad term that might include acute interstitial nephritis or contrast-induced nephropathy, those are more common during the admission. So it's volume problems coming in, and then some sort of iatrogenic or hospital-associated injury, something they picked up while they were under our care, is most common later on. So when we see an AKI, the best thing that we can do to prevent it from getting worse is easier said than done, and that is to optimize volume status. In some ways, that's sort of a relief, because the very sort of technical differentiation between what type of acute kidney injury it is it acute tubular necrosis or contrast-induced nephritis, or is it acute interstitial nephritis? All that kind of goes away, because the answer in all settings is to optimize the patient's volume, support them, get them through it, and be really, really meticulous about running the medication list. The fact is, though, those things are all really difficult to do in real life. Volume status in particular is often a little bit more art and a little less science, but those are the best things we can do. I joke about it being an art and a science, maybe more art than science. And I've been at this for a while now, a couple of decades, and I think we're all waiting for the magic bullet to tell us how to assess volume in our volume status in our patients. Briefly, it was maybe the echocardiogram and then the BNP, and then more recently there was lots of exciting press about POCUS and looking at the IVC or looking at the liver or different things. But the fact of the matter is, nothing works all the time. And so volume status really ends up being, part of the reason I love volume status actually, is it really ends up being kind of a synthesis of everything we know about the patients. So all of the information we know about what they look like coming in, what they look like now, what they told us, what their family at the bedside told us, what we learned from their distant cousin who hasn't seen them in a year, and also all of the labs that we're tracking during the hospitalization and the trends in those labs. All that kind of comes together to help us synthesize the volume status. And then, truth be told, as often as not, we end up making our best guess, going for it, and then seeing how they respond to that intervention. So if we give them a good volume trial and they get worse, well, then that was perhaps the wrong direction to move, but at least now we know. So I think it's really fun, in part because it's so difficult, and in part because it's such a synthesis. It's so much about using everything we could possibly know about the patient to try to get them on the right track. In terms of the medication list, there's a couple things to be aware of. I think antibiotics and non-steroidal or NSAIDs get lots of press. I think we're all on the lookout for those. But man, don't forget the PPIs. Even the chronic PPIs have been known to present with nephritis, and that sometimes happens during hospitalization. So the sort of old saw about whether or not somebody needs dialysis, or at least needs urgent dialysis, is the AEIOU acronym. So that's severe acidemia, electrolytes, which is almost always potassium, some sort of ingestion or poisonous exposure, severe volume overload causing lots of respiratory distress or respiratory extremis, and then uremia, which is usually that includes severe encephalopathy, where people are having difficulty controlling their airway and things like that. So AEIOU, still a good acronym. Just we have to remember that the only electrolyte, or the primary electrolyte, is potassium, and then uremia is really only if the encephalopathy is incredibly severe. Medication accumulation can sometimes be an indication for dialysis. Sometimes encephalopathy in and of itself can be an indication for dialysis. But man, I feel like the vast majority of the time when I'm seeing patients and we really start to get what really makes us worried is the potassium. Multidisciplinary involvement, particularly nephrology involvement, is critical to help with really difficult cases of acute kidney injury. Of course, for end-stage renal disease patients, especially new dialysis patients, there's lots of arrangements that just need to happen. The patients have to have a dialysis chair, they have to have transportation to and from that dialysis center, the appropriate outpatient follow-up and med adjustment is all really critical. We often see people, particularly if they're new to dialysis, we see them sort of at their worst when they're on a lot of medications for acute issues that hopefully over the weeks and months as they get established on dialysis will get better. Blood pressure medicines are perhaps the best example. We often see people who are on 4 or 5 or more blood pressure medications right before they get started on dialysis, or after they get dialysis for several weeks or several months as their volume status gets back to where it sort of ought to be or closer to true physiologic normal, those medications fall away. And so we've got to make sure that they're in touch with the right people in the right clinics to help adjust those medications moving forward. One thing that I'll say can be really useful is extra eyes. So bringing extra people in, whoever those people may be. If it's a cardiorenal case, maybe it's the cardiology team as well as the nephrology team. Perhaps it's just the nephrology team. But having other people come in who are also expert at assessing volume, but perhaps differently or through a different lens or through different mechanisms can be really, really helpful. And I think that can help us move forward with greater confidence and also have, I think, a little bit more comfort in initiating a volume challenge or initiating some sort of therapeutic trial, and then knowing that there's other people around to help us assess and redirect if necessary.